Right, let's talk about the INSTEAD XL trial. This is the 5-year follow-up to the original INSTEAD trial, and honestly, it's a cornerstone paper for managing uncomplicated type B aortic dissection. You absolutely have to know this inside and out for your FRCS Viva.
So to really nail this for an examiner, we're going to break it down into 6 key areas. We'll start with the PICO statement, then appraise its internal validity, do a deep dive into the stats, cover the key results, look at its external validity and limitations, and then wrap up with the final verdict you need to deliver.
Okay, first things first. You must be absolutely crystal clear on the clinical question. We'll use the PICO framework to pin it down, because that's the foundation for any proper critical appraisal.
So our population was patients with stable, uncomplicated type B dissections, specifically in that subacute to early chronic phase, so anywhere between 2 and 52 weeks after their symptoms started. The intervention was TEVAR, using what were then early-generation stent grafts, on top of optimal medical therapy. The comparator was just optimal medical therapy on its own, so tight blood pressure control and surveillance, with a plan to intervene only if complications showed up. And the primary outcomes we're interested in at 5 years were all-cause mortality, aorta-specific mortality, and overall disease progression.
Right, now let's move on to the critical appraisal of the trial's internal validity. This is where you really show the examiner that you've understood the study's design and where any potential bias might be hiding.
The first crucial point to make is that INSTEAD XL isn't a totally new trial. It's the pre-planned long-term follow-up of a proper randomized controlled trial. And, importantly, all the analyses were done on an intention-to-treat basis, which is a major strength.
And here are the key methodological strengths you need to highlight. The randomization was solid. They used center-stratified permuted blocks, which is great for minimizing selection bias. Now, obviously, you can't blind patients or surgeons to a TEVAR, but, and this is critical, the outcome adjudication was done by an independent blinded committee. That really limits detection bias. And a huge point to mention, they had 100% complete follow-up over 5 years. No patients lost. That's fantastic. It means no attrition bias.
Of course, no trial is perfect, and a good appraisal has to tackle the limitations head-on. The examiner is going to expect you to have thought critically about the unavoidable issues, especially the lack of blinding and patient crossover.
So you explained that the lack of blinding is an inherent limitation in pretty much any surgical trial. It's accepted. As for the crossover, you'll see a lot of patients in the medical arm eventually need a TEVAR. But that's not a failure of the trial design. In fact, it's a key finding that reflects the natural history of the disease. Finally, they excluded high-risk patients, which, yes, limits generalizability, but it actually strengthens the internal validity for this specific, stable population.
Okay, now for the statistics. This is an area where candidates can really shine or, fall flat. To really excel, you have to understand not just what the investigators did, but why they did it.
The primary analysis used standard time-to-event methods. So they built Kaplan-Meier curves to visualize survival over time, and then they compared those curves using the log rank test. Pretty standard stuff.
Now, when you look at these Kaplan-Meier curves, one thing should just jump right out at you. You can see it clear as day. The curves cross. For mortality, the red TEVAR line starts out a bit worse than the blue medical therapy line, meaning more early events. But then, around the 2-year mark, they cross, and then they really start to separate.
That crossing of the curves isn't just a pretty picture. It's the graphical sign of a massive statistical issue, a violation of the proportional hazards assumption. All that means is that the effect of the treatment isn't constant over time. The risk from TEVAR is different right after the procedure compared to, say, 3 or 4 years down the line.
Now, the investigators were smart. They anticipated this might happen, so they correctly pre-specified a landmark analysis. This is the right tool for the job. It lets you chop the analysis into different time periods, in this case, before and after 2 years, to properly assess that changing treatment effect.
And this table really gives you the punchline. For the first 2 years, the hazard ratio for aorta-specific death was actually greater than 1. That's the upfront procedural risk of TEVAR showing itself. But from 2 years to 5 years, look at that. The hazard ratio drops significantly below 1. This demonstrates a clear, delayed benefit for the TEVAR group. This trade-off, early risk for late benefit, is the absolute central message of this trial.
So now that we've got the methods down, what were the definitive 5-year results? You need to be able to state these clearly and with confidence.
Okay, here are the headline results. At 5 years, there was no statistically significant difference in all-cause mortality. But, and this is the killer point, there was a statistically significant reduction in aorta-specific mortality, favoring preemptive TEVAR, with a p-value of 0.04.
And you can see that delayed benefit again on these curves. After that 2-year landmark, the curve for the TEVAR group just plateaus, very few late events. Meanwhile, in the medical therapy group, those aorta-specific deaths just keep on ticking up, year after year.
And it wasn't just about mortality. Preemptive TEVAR also significantly cut down on disease progression. This was mainly because it prevented late aortic expansion, rupture, and the need for those late, often emergency, crossover operations. And the mechanism behind this benefit is the stent graft inducing thrombosis in the false lumen, which then leads to positive aortic remodeling.
This slide shows you exactly what that looks like. On top, you've got the dissected aorta before treatment. And on the bottom, 5 years after TEVAR, you see complete thrombosis of the false lumen and a stable, remodeled aorta. This kind of positive remodeling happened in almost 80% of the TEVAR patients. Just incredible.
Okay, so we've established it's a solid trial internally, but now we have to think about external validity. In other words, who in our current practice do these results actually apply to? Acknowledging the trial's limits is what separates a good appraisal from a great one.
Here are the 4 key limitations to rattle off. First, this was a highly selected, stable group of patients. You can't extrapolate these findings to acute, complicated dissections or patients with something like Marfan's. Second, the tech is dated. These were early-generation stent grafts. Our modern devices are much better. Third, the landmark analysis, while it was the right thing to do, does introduce some observational elements. And finally, you have to consider the patient. This late benefit might not be relevant for an older, comorbid patient who may not live long enough to see it.
Right, time to bring it all home. You need to synthesize all of this into a clear, sharp, consultant-level conclusion. This is your final statement to the examiner.
Your summary statement should be this. Instead, XL is a practice-influencing but not universally practice-changing trial. What does that mean? It means it provides the level 1 evidence to consider preemptive TEVAR for select, stable patients to improve their long-term aorta-specific outcomes. But you have to accept that early procedural risk. Patient selection, their anatomy, their age, and of course your center's expertise are absolutely critical.
So, in conclusion, for the purpose of AVIVA, this trial is a clear pass. It's methodologically robust for the question it asks, and it provides crucial long-term clinical insight that fundamentally shapes our modern, individualized approach to managing this really complex condition.